All right, guys, well, welcome to this pharmacology drug class review in the category of anti-diabetic drugs with a specific focus on alpha-glucosidase inhibitors. Now, this drug class is part of many other drug classes in the category of anti-diabetic medications that give us as clinicians a lot of options to offer tailored control of patients with diabetes. However, we will see that out of all of the anti-diabetic drug classes available, this one in particular has the least amount of use. And that will become very obvious here as we cover the content, okay? With that, I'm Dr. Busti, and thank you for joining me on This Is Why, a show dedicated in helping healthcare professionals understand the why behind pharmacology and the drugs that we use every day. When you understand the why, the how becomes easier, doesn't it? And that makes mechanisms translating into therapeutic effects, and even in this case, we're going to see side effects and monitoring counseling points very relevant. All right, now with all of the drug class reviews that I cover and do for you guys, we cover core content, and that means we cover the agents, the indications, common uses, what is the overall net benefit, and we start diving a little bit more in this specific mechanisms and some pharmacokinetic dynamic considerations as it relates to pharmacology, and then kind of wrap things up when we start doing some clinical application and little pearls that you should know as you kind of start to apply this or see them and used in clinical practice. All right, so with that, let's jump into our agents. We have two. They've been around. This class has not grown significantly over the course of its time, and that in part tells you something, right? If a class of drugs is not continuing to see new options come into it, it's probably because there's a perception and evidence that maybe it's not as effective as we would hope it to be. And unfortunately, there is some truth to that in this case. So we have Acarbose and Miglitol are our two main agents for this group. Okay, let's now move over into the indications and common uses in clinical practice. Now, straightforward, type 2 diabetes, not type 1, type 2 diabetes as an adjunct, okay? So very rarely you will, I've quite honestly never seen it used by itself, but it's an adjunct to diet and exercise. Now, Acarbose also more specifically has a use in postprandial, hyperinsulinemic, hypoglycemic gastric bypass surgery. Right? So there's a lot of things that happen in that clinical scenario where this drug can be beneficial. All right, now we're going to move over into our net benefit of the class. Why would we go to it? All right. So every drug class should be that's on the market should have some reason that we would use it. And that's what pharmacotherapy is all about, picking the right drug for the right patient in the right clinical scenario. And sometimes we may not use it very often, but there might be an opportunity, like I presented to you with indications and uses where that can be relevant. So it's weight neutral. And we know that some of the older drugs in particular can facilitate weight gain. Even insulin itself does that, right? Low hypoglycemic risk and modest reductions in A1C up to 0.8%. So if someone's close, right, and they want another option that's not going to do, cause weight gain or increase the risk of hypoglycemia, then this is an option. However, that benefit, which sounds great overall, is offset, unfortunately, by side effects. And those adverse GI side effects, unfortunately, take that benefit and start to shrink it down or make it sometimes in the negative for some patients, okay? And that's important for us to know. So it's to learn things and the use of drugs in its clinical context. Okay, now we need to move and start shifting over into the pharmacology, pharmacokinetics, dynamics, those kind of considerations. And then we'll start to migrate over into how does this drug fit in the overall picture of treatment options available to us for the management of diabetes mellitus. Okay, so pharmacology, when we say that they're an alpha-glucosidase inhibitor, well, that makes it straightforward, doesn't it? So that is an enzyme. Now you need to know that the enzyme is in the small intestine, and that's why people develop the GI side effects. This is clearly why, and a good example of the why, where the mechanisms translate into the unfortunate adverse events that really compromise the overall application and clinical practice of this drug. Makes it hard on patients, but it delays the breakdown of these complex ingested carbohydrates into the glucose that we would need for absorption. And specifically the way it does that is that it prevents the metabolism of also sucrose to glucose and fructose. And that matters because if you have this drug on board and you have other anti-diabetic drugs that are being co-administered, which is almost all the time, okay, then those set up the patient potentially for hypoglycemia, especially if it's a sulfonylurea, Miglitol, or insulin, and you need to give dextrose and you do choose to use it orally. Well, you've got to give glucose, because if you give a complex carbohydrate in some other format and this drug is present, then that would prevent the basically metabolism of that and prevent the delivery of the glucose to the body in that scenario. So in summary, the pharmacology here is a delay in glucose absorption. So it's going to work on that post-meal or postprandial glucose rise. And that's its main pharmacology, okay? Now, what we need to transition to is taking that pharmacology, taking some of the indications and uses, taking some of this context about the side effects, where does it fit in the overall management of type 2 diabetes in particular? So one of the things that I put together for you are some tables. Again, these tables, like all of our tables and images that we use in these lectures, are available at thisiswhy.health. That is the website for the show and the channel. It's free membership to be able to download these. The link to this episode's content is in the description, so please check that out, and feel free to download it, use it for studying, sharing with friends, colleagues, use it for teaching if you are a preceptor or faculty, if it's helpful to you. So this particular table is about the general, like really high-level strategy of diabetes, and I'm not trying to insult anybody's intelligence here, but depending on what level of training, what level of experience you have, and when you're listening to this, I just want to make sure that we're all on the same page, because we have type 1 and type 2 diabetes. And I've tried to break that down. What is the basic, not complete, not every potential comprehensive treatment decisions that are made, but what is the overall treatment strategy? I mean, obviously with type 1, these patients lack insulin. And so we are obviously using insulin delivery in different methods, right? There are a couple drugs like pramlintide that can be added to that. Whereas type 2 is predominantly, well, you still have a functioning pancreas in many cases. Maybe it's burning out, depending on where you are in the disease process. But you have a lot of treatment options here. And you see the very first thing is medical nutrition therapy plus physical exercise, right? Those things cannot be ignored, okay? So when we talk about adjuncts, when I was talking about the indications and use, these drugs would be assuming that you're using them after those first two things are done. And then, of course, as you go down each bullet, there's this sort of progression, right? So monotherapy or combination therapy of a non-insulin-based therapy. Why non-insulin-based? Because we don't want to facilitate weight gain, increases in hypoglycemia. So if we have drug options and therapies that help patients to lose weight, which is typically a problem, we're going to have lower risk of hypoglycemia. We're going to get A1Cs to their goals, and we can get there with without any reasonable complications or costs to the patient. Then we should try to do that. But then you see that bullet 2 says there, add insulin, okay, and then you progress onto the insulin and making sure you then treat other metabolic things. So that's the big sort of picture, but that doesn't outline what non-insulin-based therapies are we talking about. And so that's the second table that I'm presenting you here, which are, these are the secretagogues. And if you're not familiar with that term, secretagogues are drugs that would facilitate the secretion or release of insulin from a functioning pancreas that still is able to make insulin, right? So you got your miglitinides like nitaglonide, repaglinide, you got your sulfonylureas, the old school drugs, the first generation agents, which we don't use anymore, and then our second generation, which have fallen down in clinical practice. Still see them occasionally, glyburide, glipizide, those kind of medications. Those are facilitating the activation and turning on of the pancreatic beta islet cells to release more insulin. So that's not where we're at here. Right? That's going to, all these drugs in this group are going to facilitate beta cell burnout and the progression of type 2 diabetes over time, which is why they have decreased over time in their own use in clinical practice. Whereas the third table are the non-secretagogue agents, which are also non-insulin based treatments. And this is where the class, subclasses, if you will, have really grown and proliferated over the past several decades. And I watched that happen in my 30 years practicing as a nurse, pharmacist, physician. It's amazing what these drugs have now are doing for the disease and really trying to get a lot of the underlying problems associated with type 2 diabetes under control. Weight, insulin sensitivity, management of their control. And now we're also affecting kidneys better and preventing cardiovascular disease. It's amazing how these drugs and research has evolved. This is a great representation of that. But up here at the top, this table breaks down each row represents a drug class in the anti-diabetic non-secretagogues sort of family. And so alpha-glucosidase inhibitors sit right there. And so I try to put tables like this together because I think it's important that as you're learning these drugs, that you learn them in the context of other drugs. How do they work? What's their similarities? Especially if this is the first time and you have to memorize some things. Nothing wrong with that. We all have to memorize facts. They are what they are. Sometimes it's not intuitive, right? But you need to understand like mechanisms when you are memorizing that. You need to go, so what, who cares? What does that mean for my patient? And it should make sense to you then. You should be able to predict potential problems or issues if I try to treat an overdose or treat a patient with hypoglycemia or some scenario, okay? And so I try to put those together there for you. Again, those are available at thisiswhy.health. Now, the last table here is looking at the consideration of anti-diabetic drugs in the context of comorbidities. So if I have a patient with certain type of medical conditions, what drugs might be preferred? And again, this is not a perfect table. It's not the end-all, be-all. But it's a high-level consideration, right? These would be great types of content areas for board exam kind of questions. There are the nuances, the little pearls, the things that you want to kind of keep in your mind. Again, how does this drug class compare to the other drug classes for the ones that we would want to consider? And so when you look at the left column, that's the medical conditions. So you got overweight, obesity, dyslipidemia, right? Renal impairment, heart failure, cardiovascular disease, gastroparesis, irritable bowel syndrome, inflammatory bowel disease, and moving on, right? So those are various medical conditions. And then the middle column is like, what would you consider? And you really don't see alpha-glucosidase inhibitors really in here. Now you could say, well, maybe up here in the overweight, obese, because the GI side effects may decrease your desire to want to eat. Maybe, but they're really not used for weight management like the other drugs that are listed there. So it's not really anywhere on here in the consideration. And that's the take-home point. That's why these drugs are rarely used. I mean, I have not seen a patient on these drugs in quite a while, even though they're still available on the market. I'm not saying that I've never seen it, just fallen off, right? Especially as the evolution. But where would I avoid, which is that last column? So if you look here at the GI side effects, we have inflammatory bowel disorder, irritable bowel syndrome, patients with known partial obstructions or high risk for obstructions. These would be kind of the bubble of patients like, yeah, you probably really want to avoid this drug class for sure in that group, okay? Just because the side effects are going to be too significant. Okay, so let's continue on and talk about our dosing and dosage forms, administration kind of issues. These should be titrated, okay? Like a lot of drugs nowadays are titrated, especially for weight loss, right? So people are used to that, but really you got to do that. You got to get acclimated to this. So you want to start with one meal, and then you acclimate by adding it to additional meals until you get to basically all 3 meals. Hopefully that's all you're eating in a day. And you want to start at a low dose. And you want to do that, take the medication around the first bite. Okay, because again, remember, it's trying to delay the breakdown of those complex carbohydrates into glucose where you would absorb it. It's going to affect the post-meal, postprandial glucose changes that sometimes we will actually measure in clinical practice. Now, there are some weight-specific considerations with Acarbose that is worth your recognition here. Again, board exams aren't going to ask you that kind of level of detail other than the concept, all right, that there are some specific weight-based considerations that you might need to make, and there's very little bang for the buck if you go too much above that. All right, now what about kind of contraindications, warnings, these kind of things? Well, we talked about the impact on the GI tract. So if you leave complex carbohydrates inside of the bowel, there's other things in the bowel, bacteria that love to party on those things. And one of the things they're going to produce is a bunch of gas, a lot of it, okay? And that is probably the biggest problem. So that's where if you produce gas, you're going to cause gastric distension. That may expand, irritate the gastric mucosa itself and the lining and cause spasms. So people with irritable bowel syndrome, inflammatory bowel disease where they have spasms and diarrhea and different variations thereof, that's probably not going to help them. And that's where patients with these digestive issues or partial obstructions become relevant. Acarbose in the context of patients with true underlying cirrhosis. Again, remember our liver is the first thing that food and other things that we consume, it's going to go through the portal circulation goes through there. And so when we modify the dietary components and the way our body handles them, that may exacerbate other conditions. So it's just considered generally one of those things, we're not going to do it. From a renal impairment standpoint, there are recommendations that for severe renal impairment, and that's in most cases less than 30 GFR, where you see it. Now this one's less than 25, but maybe you're going to increase the concentrations. But remember, this predominantly works in the bowel. So it's I mentioned it, but yeah, whatever. It's like small subject. I don't think anybody's going to really ask a kind of question about that, but to try to be comprehensive. Now, GI side effects from a monitoring standpoint is your biggest one. So that counseling point about application and administration timing with your meals and the titration to acclimate in the same context of GLP-1 agonists, things like that. You do the same thing, titrate the drugs to maybe more acclimate to it. And then every 3 to 6 months, depending on the patient's goal, where they're at in their hemoglobin A1C will then influence that. You may also check what is called a postprandial glucose before starting and afterwards and see how if that's working to impact it, which it should. Obviously, liver function tests are going to be impacted. Serum creatinine, for those reasons we just talked about, again, doesn't seem to be a big or major component. Now, again, the counseling point is around that use of dextrose. If somebody is having hypoglycemia, not sucrose or complex carbohydrates, so they need pure glucose in that situations. Otherwise, the medication itself will delay the absorption of the glucose because that's how it works, right? Moving on to pediatrics, special patient population. It has been used in patients that are 10 years and older. And so just keep that in mind. It's, again, evidence is largely experimental in nature. Okay, now we're going to start to wrap things up. Remember, this is the drug class Alpha-Glucosidase Inhibitors. We're talking about Acarbose, Miglitol, primarily used for type 2 diabetes. Mechanisms, delays absorption of complex carbohydrates and that absorption of glucose in relation to a meal. So it works in that postprandial glucose rise, okay? But obviously leaving complex carbohydrates in the bowel causes a lot of flatulence, bowel gas, gas pain, stretching, spasms, bloating, discomfort. You have no friends, no one wants to be around you, that kind of stuff, right? But it is weight neutral, low risk of hypoglycemia. You just got to remember to use that dextrose if you find yourself in a situation and need to replenish it because you've been on some other medication that's lowering it. All right, guys, I hope you found that to be helpful and put in the proper context of other anti-diabetic drugs. If you haven't done so, please join us on YouTube. Be a subscriber. That really helps us. Also, give us a like, turn on that bell so you get alerts to other topics that come out. Also, consider joining thisiswhy.health. Submit a topic of interest, a question that you might have. It could be a future episode. There's also things there like collections, playlists, and those downloads to the tables. I'm Dr. Busti. Thank you for joining us, and never stop learning the why, because that is what makes the how so much easier. Take care, guys.